Wonderful. Good morning, everyone. It's great to be here, good to meet you guys. Finally, a lot of names with Dr. West in particular. I've been working with you for a while, not knowing, so it's great to get to know you guys in person. We're going to briefly talk about EMGs today. I tried not to make it boring after a few talks over the last few weeks about how to live healthy and have a meeting on the ski slopes and so sort of fun stuff. It's probably a bit boring, but you probably have a talk like this to appreciate the other good ones. So just bear with me if it gets a bit too technical. I try to avoid that. So, we've come a long ways. This is where EMGs in the past used to be done. This is our current machine. So all of this is translated into this amplifier, although you can argue and say the setup for chairs and the patient setup was much better than compared to our rough table these days. But putting that aside, I think all of this discomfort has basically been bundled into a small amplifier. 6 out of 10 patients, basically, when we do EMGs, they just say, wow, I shouldn't have worried about it too much. They read about horror stories, how difficult this test is. But after it's done, if you really plan it and don't make it like a big poking test, it's not usually as bad. But the big difference of an EMG with like any test, as we were talking with Dr. Edwards, you want to have a rationale to order a test as simple as an X-ray. But with EMG, it's a bit more different because you really plan one part of the test, see what it shows, and then do the other part. It's not like you do one X-ray and see the same result. So the EMG, depending on which approach you take, could have really different results. And the main question is why we're doing it and what are we trying to get out of this test. So when we perform the EMG, what is it that you guys like? I mean, I'm just curious in your practices, do you guys ever order EMGs? And if you do, what are some specifics that you want to learn about this test? Any comments?
I think for me, sometimes is it a peripheral nerve issue? And distinguishing that from like a cervical or lumbar radiculopathy.
Great. So nerve root lesion, injuries to the peripheral nerves. What else? Any other reasons to do an EMG on a patient? Yes, sir.
The severity of it, of how is this something I can treat the carpal tunnels with just a brace or injections, or if they have demyelinating processes or the motor nerves are starting to be affected, that's a little bit more serious and something.
Exactly. All right, great point. Yet, in particular, like carpal tunnel. So if you look at the nerve, for instance, like a wire, there's insulation around it, and then there's main wire. So if the damage is in the myelin, the recovery is much faster, more realistic, whereas if there is axon injury in the carpal tunnel case, we can tell up front to the patient, hey, you're going to get significantly better, but maybe not all the way, because there is already a lot of damage to begin with. So that'll give us a lot of good information. So the first step, ordering an EMG, is what is the clinical question, but more importantly, can EMG even answer it? Like if someone comes with trigeminal neuralgia, facial tingling and numbness, and the order says EMG rule out multiple sclerosis, that's probably not a good idea because this test is not able to test for multiple sclerosis. You need an MRI and expertise of Dr. West to look for basically multiple sclerosis. So is this even in the ability of this test to answer that clinical question? It's crucial to do before doing an EMG to know exactly what we are trying to prove or disprove. Like you have to have a good history and exam. Basically, by the time we start doing an EMG, we should have a differential diagnosis narrowed to 2 or 3 possibilities. It's not like you do an X-ray and see what we see and see what's going on. You have to have 2 or 3 possibilities and try to confirm or rule out the possibilities. And then you design it basically based on that differential diagnosis. If I'm looking for a carpal tunnel, the sensory nerve that we pick is different than if you're looking for brachial plexus. So you just have to design the test based on that clinical question, take one step, see if that confirms it, or if it's not consistent, what is the issue? And then towards the end, as we go through the test, is this basically telling us what we were looking for? Does it make sense or not? And then if not, why is not? Why doesn't it make sense? If someone let's say, if you see a patient with numbness and tingling in the thumb, what are the possibilities? I'm sorry?
Carpal tunnel.
Carpal tunnel, sure. So then we do the EMG, just say, okay, this is carpal tunnel. So we do it, and median sensory nerve response is normal, which in carpal tunnel we anticipate it to be abnormal. So then the question is, did I do it wrong? Was it not enough amplitude? Did I misplace electrodes? Or if it's truly normal, then what's the reason that the test didn't confirm that? Any other suggestions? Hi. Okay, so it could well be like a C5 radiculopathy, right? So then when you see it's not, if you think it's carpal tunnel, but the test does not show carpal tunnel, then the other possibilities, then we start testing with muscle. So you change your plan, basically. It's not like a static test. All right, so can a test hurt a patient? Any test, like as simple as X-ray or EMG. We're talking about non-invasive, procedure for the most part. But how can a test hurt a patient? Thoughts?
They have a lot of anxiety about it. Not necessarily.
Great, right. Not sleeping well, like EMG patients, they say, I haven't been sleeping for 7 days on it since my neurosurgeon referred to you, so that's a big one. What else? Yes, sir?
Yeah, it goes back to why you're ordering the test in the first place, because you could order a test and end up with the result that you then go down a rabbit hole with and don't know what to do with the answer. An incidental finding of something, and now you're doing more tests.
Exactly.
It sort of leads to, it seems like just a test, but it actually can lead you down the wrong path.
Absolutely, yeah. It's incidental finding, not relevant to this, but somebody comes with some headache, and we do stroke workup, and we do an echo and see a small PFO, a hole in the heart, and then PFOs are so common, so the question is this causing or not? So we go and do another test and see something else in the heart, and it can go forever. So it's always important to say, hey, do we even need a test? Because every test, no matter how simple it is, has a potential to create that issue. So if it's a wrong test, that could hurt the patient. If you're looking for MS, but you're ordering EMG, that's not right, because it doesn't have that ability. So it could be wrong for diagnosis and treatment. Or wrong results if the test is conducted inappropriately, if the results don't make sense. Like you have a patient that has a lot of edema, and you cannot stimulate too much with the nerve conduction to get the normal response. By mistake, that's interpreted as abnormal nerve results and neuropathy and surgeries and so forth. So if a test is done wrong or interpreted wrong, that can hurt the patient. And then two-way street, like unnecessary surgeries or procedures based on the test, or delaying the surgery or procedure that patient actually needs. I had a case to bring up, but in interest of time, we kind of skip it. But the summary was, maybe I can show you this. Actually, this is the report of one of the EMGs I saw recently that was done outside, referred to us by one of your advanced practitioners. This patient presented with some balance problem and tremor, and then the initial step was just to do a test. Instead of doing an exam, formulating differential diagnosis, then doing a test based on that, the first step was, okay, some balance problem, tingling, let's do a test and see what it shows. And this is what it reads. So if you guys want to read through it a little bit, what catches your attention? That you ordered the test to get some results, but just see if you guys can pinpoint a few issues that could come arise from this, and then I'll tell you how realistically what did this report did to the patient. So it's talking about a very complex test without clear results. The EMG shows pretty much every single muscle is abnormal. All the nerve roots are abnormal. And then this is most likely indicative of an active, unchronic radiculopathy, small nerve root region, could be a motor neuron disease like ALS or Lou Gehrig disease. And then also could be a neuropathy. And then recommend collaborating this with lumbar spine imaging and neurology consult, which in reality should have been the opposite, right? You want to start with clinical diagnosis, then diagnostic imaging, and then a functional test. But what happened with this particular patient was had some tremor, balance problems, a little bit of foot drop, saw somehow the EMG was done in an outside office. This was the result. Patient was referred to neurosurgery for polyradiculopathy and foot drop. It took 6 weeks to see you guys. And then patient got the report and read to motor neuron disease, which is ALS, Lou Gehrig disease. So the guy said, oh, drooling, ALS, Google, that's ALS. So I got ALS. So for 6 weeks, their life was upside down. And patient thought they had ALS. So even didn't want to show up for the neurosurgery appointment. Say, I'm dying, why are we going to the appointment? Right? So then a smart neurosurgeon came and they just said, no, we don't think this is a back. This multi-level doesn't make sense. You can't have everything abnormal. The foot drop is not only on one side, it's actually on both sides. Then maybe let's see what else is going on. And then this patient actually turns out to have peripheral neuropathy related to diabetes, which caused some bilateral foot drop, and also Parkinson's disease with the drooling and tremor, which Parkinson treatment is quite different these days. With DBS neuromodulation, they do really well, but ALS, Lou Gehrig's disease is like a fatal, like a death sentence. So just doing a test as simple as that and putting this bunch of information for a patient that now they have access to medical records could really hurt them emotionally. All right, so we talked about let's briefly talk about what EMG can do and what cannot do, and then we talk about a specific case, hopefully, if you have time. So to me, EMG is mostly important as augmentation of the physical examination. It just gives you a better perspective of what's going on with the peripheral nervous system. It narrows the differential diagnosis. Like if you have someone with lower extremity numbness and tingling, is it GBS, is it neuropathy or MS? So it can help us narrow the differential diagnosis, determine the severity of a condition, as Dr. Pitt say, how bad of a carpal tunnel it is. Is it moderate, mild, or severe? Does it need surgery? If it's pretty mild carpal tunnel, you may not need to do the surgery in the first place. And then determine the prognosis. I don't know if you guys see patients that have chronic back, like if someone has a chronic back issue with some nerve damage to begin with, and you see a disc superimposed on that, what do you guys usually tell them? Like, do you tell them that you can, if a patient asks you, am I going to get all better? Is it going to go away? It depends on what they have to begin with. If you already have a significant nerve damage, you may not get full recovery because there is some pre-existing situation. So this can tell us what the outcome of a potential surgery or treatment is. And then evaluate the function. I'll put it in interest time, I'm going to pass that. But another important piece is evaluate integrity, especially in like orthopedic or hand surgery after like lacerating injuries, radial nerve injuries, humerus fracture, that can provide information about that. Okay. There are stuff that EMG cannot do. And I should have probably asked the question first before putting the slide up. But there are conditions that EMG cannot answer. For instance, anything in the central nervous system, EMG cannot answer. A lot of time we see a patient with classic neuropathy. So what is a classic patient with like diabetic neuropathy that you'll see in clinic? What are the typical symptoms and presentation? Somebody comes with, that you think, oh, this is textbook peripheral neuropathy.
Numbness and tingling in their feet.
Mm-hmm, right. So numbness and tingling in the feet. What else? Like there are more specific criteria that numbness and tingling has to be a little bit, it has to be symmetric. If it's asymmetric, it's usually suggestive of inflammatory neuropathies. So a patient comes in with diabetes, tingling, numbness in feet up to the calf, that's diabetic neuropathy, right? You send for EMG, EMG is normal. That does not rule it out. If you have the right clinical differential diagnosis, it could be a small fiber neuropathy, which does not. So if you ever test for neuropathy, you get two results, either a small fiber or large fiber. EMG cannot answer the small fiber. You have to do a skin biopsy to count the nerve fibers to see if there is small fiber neuropathy. And then the other big thing is the timing of the EMG, especially related to nerve injury, peripheral nerve injuries. Like it takes usually 3 to 4 weeks for the defibrillation, and we hopefully can talk about those changes a bit later in the talk, but there are some specific changes that tell you how much nerve injury you have. If you do the EMG right away, that often could be falsely normal because of that so-called Wallerian degeneration. It takes time for the nerve damages to be seen in the muscle setting that you can actually test it. And then at the root level, L12, C12, C4, EMG is pretty limited because there is no corresponding muscle in the limbs to test. So if you see an EMG that's normal in the upper extremity, but you're really thinking of cervical spine etiology, is probably some central etiology. Okay, so in neurology, we like to keep things simple, right? So it's upper motor neuron or lower, this slide pretty much says a lot of it. Like just by this differentiation between these two categories, we can rule out or confirm a lot of things. So upper motor neuron disease, what are the typical signs or symptoms you want to see, like in stroke or MS patient, compared to lower motor neuron, which is the peripheral nerves? I have the answers here, but if you're honest and don't look at it, so if you want to give me a few examples, what do you expect if someone, let's put a case together. Someone comes to the ER with 3 to 4 days of progressive lower extremity weakness. What do you want to see in the exam to suggest this is Guillain-Barré versus a stroke or multiple sclerosis? Just that ER encounter, that simple exam should give us that. So what do you guys think you like to see in that patient to suggest is Guillain-Barré?
Reflexes.
Yeah, reflexes are.
Oh, I'm not gonna.
So diminished reflex, right? Yeah, so absent reflexes. So if that patient comes with clonus and Babinski and 3+ reflexes, that's probably a cord compression or MS or stroke. But if the reflexes are absent, that's more like a peripheral nerve, Guillain-Barré. So just this differentiation between upper and lower motor neuron disease, just on the symptoms and exam can give us a lot of information. But EMG actually is able to, let's go through this. I think I missed a slide. Okay, so EMG is designed to test the peripheral nerves. Doesn't do anything with the central nervous system. So you can learn anything from the nerve root to the plexus to the peripheral nerves, nerve and muscle junction, the muscle itself, and the combination of this. So it should actually provide good results. So when you do an EMG and you have a clear clinical question, that EMG should be able to answer that fairly clearly, which of these areas you're dealing with. Because if you just put every single possibility like that report, that's not going to help the case. All right, so now we're going to do our case. This is a case that I've been working with Dr. Edwards' team as far as diagnostic and treatment. And most of the cases that we want to see are puzzles like this. We want to say, hey, it's an easy puzzle. But most of the cases turns out to be a puzzle with like 1,000 pieces. So this case started with that. There was a 47-year-old female with low back pain and right leg pain and weakness in 2019. Pretty straightforward. Had MRI, symptoms were matching, had surgery in the lumbar spine, like a laminectomy, I believe, and did great. Symptoms went away, everything perfect. So what happens next? 5 out of 10 times, there is always, I fell and messed it up, so they fell and injured the surgery site. The symptoms came back, and then end up having 2 other surgeries over a course of 2 or 3 years that did not provide any significant relief. Majority of her issue is the weakness around the ankle dorsiflexion, plantar flexion, some pain, but her concern is, I want to go hiking, I cannot hike, my foot doesn't work, I just need that fixed. I'm willing to go for 3 other surgeries if you can fix that. Okay, so putting that case aside, if someone has right leg weakness, what is the differential diagnosis? What do you, if you see someone with this symptom, what is that comes to the mind before we formulate our diagnosis? Dr. Ansha? No volunteers?
So you're thinking about either you go from peripheral to the central
Sure.
or central to peripheral.
Exactly,
Because
right.
I deal from peripheral, don't want to go central.
Yeah.
Mononeuropathies
Great.
can cause lower extremity weakness. Nerve injuries can cause right lower extremity.
The common peroneal neuropathy. In the first category, like lupus-induced neuritis, that could do the same thing. Perfect.
And joint dysfunction
Exactly.
can cause weakness.
It could be non-neurological, like a lot of times we just stuck on the nerve and it's not the nerve, it's actually the joint. So if the foot doesn't work, it could be the ankle. Excellent.
Muscle tendon tears
Mhm.
can cause weakness, and higher up plexus injuries or plexus malfunction, lumbosacral radiculopathy.
Wow, you're hitting it all. I'm just having more options.
I won't go higher
I
than
think
that.
it brings up an important point here, because like in this case, in my mind, I pretty much know what's going on, right? She had a surgery and then had a disc herniation. She had a discectomy. The disc herniation was calcified. The nerve was stuck. It was really tough, and we went back in and fused it and cleaned it out thoroughly. So we think that this is probably a chronic nerve injury. The MRI says that there's scar around the nerve, but there's scar around every nerve when
Exactly.
you do a surgery, right?
Right.
So the EMG in this case is that really what's going on? How chronic is the injury? And then it kind of is the reverse of where you started, right? Where you want to do your history and physical and then test with a specific question. But at the same time, does this EMG test pull in other possibilities? And do you want to know about those possibilities? Because it could be something else. And
Sure.
we always want to make sure that
Right.
we're not just
Right. Yeah. Absolutely. Like, yeah, that's exactly right. If you know about the history, of course, that's the past. But what I was trying to say is, if you just think about not the first encounter before even the first surgery, like if the patient comes to you with right leg weakness, the possibilities are in there. But then after you did the appropriate workup and narrowed it down with exam and diagnostic testing, it turns out to be radiculopathy. And actually, in this case, we will demonstrate that EMG can actually help patient make the right decision, because the patient has been pushing for surgery. I want to do another surgery, but is that really the answer? Even if every test is suggesting you need surgery. But I just want to put this slide here that when at the first glance, when you see a patient with right leg weakness, the possibilities are just beyond that lumbar radiculopathy. It could be other things. Even cervical spine disease can sometimes present with leg weakness or central pathway. But when we decide based on exam, it's in the peripheral nerves and not central, then we want to localize and see where this fits into that peripheral nervous system. These are the MRIs of that patient, and on purpose I messed them up a little bit, so I did not put them in order to demonstrate the great job that Dr. Edwards has done as far as stabilizing the spine. So can you guys guess which one was the first, which one was the middle, and which one is after the last surgery?
the one without the screws is the first one.
Okay. Of course. Yeah. So can you tell us what you see most in this first image? What's bothering you in that image? Like, what is the most prominent abnormality?
Well, initially she had an L4-5 issue.
Right.
And if I'm honest, I don't recall exactly why we fused versus doing a discectomy. Maybe there was neuroforaminal stenosis,
right,
or something.
Recurrent disc herniation.
It could have been a recurrence from the beginning.
And this, I think this was the second one that she started having a bit more issues down here. Is that correct? Like
yeah,
more down
then
here.
she herniated at the level below, which is an issue with fusion, is
right,
the adjacent segment
right.
issues.
And then this image here, I think, is the last one, right? So that everything is aligned nicely, like the spaces are preserved. The space here is not bad, and this is not the best, but this is it, like I say, 3, 4 maybe. But her problem is actually L5S1. So this image looks good. Like, there is nothing else that correlates with that clinical examination. Let's just pass this with the interest of the time. Go to the slide later. I'm going to show you the actual EMG.
So even though you say it's an L5S1 radiculopathy, it could happen at any lumbar.
Right, correct, yeah, depending on its coming. So this EMG was done 6 months ago, and the most recent. Just reading through it quickly, the peripheral nerve part looks fine, because the ankle dorsiflexion issue, plantar flexion, could be a peripheral nerve. That's been ruled out with the sensory and motor. This is where it could get us in trouble or actually help the patient. So if you look here, everything that has S1 innervation is marked abnormal. So then it's either the S1 radiculopathy or lumbosacral plexus, right? But then when you see this portion of the EMG, it tells you there is a lot of scarring previous nerve disease, like this nerve has been injured over the multiple falls and stuff that she's been through. There is a lot of activity here, but over here you already have a lot of problems to begin with. So this patient had these questions that we were going to answer. Do I need surgery? Will I get fully better? Surgery is risky. There is potential damage, but if you guarantee I'm going to get 100% better, I'm willing to take the risk of paralysis and go for it. So then we just have to answer that if we can make it guarantee that she's going to get her ankle function back, even if there's 50% chance of, like, I mean, what is the concern if you operate on a scarred nerve? There's a chance of more damage to the nerve, correct? Like, what is the concern, or maybe not getting, but what is the concern that you don't want to do surgery in this case?
I don't think it would help her. I mean, when you look at the MRI, there's nothing there that surgery would be helpful for. And I think in this case, this information, chronic S1 radiculopathy finding tells the patient a typical surgery, the way we think about it, isn't going to help.
Exactly.
Because the nerve is injured.
Right.
And so it helps them understand she wants a solution, and I think a lot of times patients are desperate for a solution, so they will do anything that you suggest to them. And by presenting this data to them, you can steer them in a direction that
Exactly.
is going to be, this is your most likely next step for resolution.
Exactly, right.
That is not another surgery.
Exactly, right. Because absolutely, like the patient was reading through the MRI report, it still talks about severe stenosis, the EMG shows active denervation, but the real answer is, patient was asking, am I going to get fully better? Am I going to get full function back? And the answer, unfortunately, is no, because you already have some significant nerve injury. So even if you can get rid of that active denervation, there still could be some residual symptoms that is not going to get better. So why put you to another surgery? So as Dr. Edwards decided and canceled the patient, and she saw the data and was more, because she's been to like 2 different doctors trying to just do the surgery, and that doesn't seem to be in her best interest. So now she's going for some conservative treatment with spinal cord stimulator or physical therapy.
That direction is another direction.
Right. Okay, I think we're running out of time, so I'll be brief. But another role of EMG is in like medical legal cases. So I just put 2 or 3 scenarios that we saw in the last 2 or 3 months. I was just hoping to maybe have a quick discussion on it, and then I'll be done. So I saw a patient with carpal tunnel symptoms, had surgery done, got a little bit better, but not much. So she was referring and said, hey, what's wrong? Why did the carpal tunnel surgery did not work? Something was wrong. The surgery was not wrong. So what are the possibilities, Dr. Pitts, that why a carpal tunnel patient does not get significantly better after surgery?
Well, their initial damage, just like with the spinal case, how much nerve damage is already present. I can think of a gentleman he's a weightlifter. We did bilateral carpal tunnel releases, but when he came to me before his surgery, he had complete guttering of his fingers. So on those ones, you just kind of set him up and say, hey, we can't regrow the nerve. And
Exactly.
I really emphasize that carpal tunnel surgery is not doing anything to the nerve other than decompressing it. That's it.
Right.
The rest of it is crossing your fingers and hoping your nerve can heal it to some level.
Right.
So
Right.
that's
It's the same with all spinal surgeries.
Yes, exactly. So, like in this particular case, we're lucky that we had like a baseline EMG to begin with. The nerve damage was significant. There was a lot of axon damage. So the patient, probably the surgery stopped the progression, but could help a little bit, but with the first EMG, a patient should be given this information and counseled that yes, the surgery is helpful, but likely is not going to provide you with a lot of improvement. It will stop the progression. Same with the cubital tunnel, for instance. So you get that good information, and then the EMG will prove that in that case that nerve was intact. And then one other case, it was actual radiculopathy, that the carpal tunnel was perfect. Before and after, there's improvement, but patient also had a double hit with radiculopathy with the thumb numbness. And then it was also too early for recovery. As you know, if there's axon damage, it could take several months to see the results. There was another case referred that a foot drop after a lumbar spine surgery along L5S1. So the first question was, yeah, the nerve was injured during surgery, but in interest of time, this was actually a common peroneal neuropathy related to positioning during the surgery. Compression neuropathy at the knee didn't have anything to do with the L spine, and patient did great after a while. There was another one, shoulder abduction weakness after C-spine surgery, concern for damaging the C5 nerve root, but the issue was actually, so what do you think, what else can be happening there besides the damage to the nerve? If someone had C-spine surgery, C5, C6, cannot lift the arm up.
Brachial plexopathy.
Yes, but how?
I mean, positioning injuries.
Positional injury, and then anesthesia. I guess these days do a lot of local blocks. So this particular one had anesthesia block in the upper trunk of brachial plexus. So the C-spine surgery. So it will be helpful as far as providing really objective data to prove that, what is the differential diagnosis? Is it real? Is not? And what is the prognosis? And then just a couple of slides and I'll be done. Just the way we do EMGs is we do the nerve conduction. This is called shocking part. So there is this electricity that's sent through the nerve. There are different nerve responses, motor and sensory. In like a myelin, which is pressure on the insulation, the distal latency is longer. Like it takes much longer for a signal from here to get here. So this is pushed here. But if there's axon damage, the distal latency is normal, but the amplitude shrinks in the setting of an axon damage. So based on that data, we can determine how much axon myelin injury you have as far as determining the prognosis. Okay, and then we have like circuit checks that you can do, but I'm going to pass that in the interest of time. And then the just last two slides I want to show you guys. This is an EMG insertional activity. So when we do an EMG, I wish we had the machine here, but we just poke with a needle. So that's normal insertional activity. Noise, everything is good. Compare that with this one. So you hit it. If you notice in the background, there was that rain in the roof sign, which is fibrillation. So that one tells us that the nerve is under pressure. Either the myelin, either scar tissue, there's a screw in the nerve, there's hematoma, there's scarring. So that is what we talk about active denervation. That usually takes about like 3 to 4 weeks to develop. And then when we activate the muscle at the very end, this is a normal activation of the muscle. So you have the patient then activate particular muscle. If you look here, you see there is different types of motor units. So that tells you the recruitment is normal. But if you compare with this one, there is just in the same screen, there are just so many of them. So that's a pattern that you see in a muscle disease. And then here you just see one unit trying to really work hard to recruit itself in a complex sound, and that's what we see in the nerve in a neurogenic disease. Perfect. So basically, I just wanted to kind of demonstrate that in the EMG we do an activation phase, and then patient actively participate. EMG is a part that you really have to puzzle and link the dots. Like if you want to do a C7 radiculopathy, you test a C7 muscle from radial nerve and median nerve. If they're both abnormal, the issue is in the source. If it's all in the radial nerve territory, like a wrist drop could be from radial nerve or from C7. All right, so I don't think we have enough time. Thanks for your patience. So I'm just going to skip through these, and thank you.